Okay, so this is my topic today, medical management of bone fragility in adults with OI. I'm going to talk about what drugs to consider and when. These are my disclosures. Notably, I have consulted with a number of drug companies that are developing drugs for reducing fracture risk in OI, including some of the drugs that I'll talk about today. I don't think these associations are going to influence what I say. Let me start by making a couple of general points. And the first is about the frequency of fractures in adults with OI. These data are from a study from Denmark. In Denmark, all the medical information in the population is available, which means we have the opportunity to study a lot of people with OI in Denmark. And here, what they reported is the fracture rate on the y-axis as a function of age on the x-axis in people with OI in the dotted lines compared to a control group of people in Denmark without OI. Males are on the left, women are on the right. You can't see the ages here, but in this part of the graph is kids. And obviously, fracture rates are very high in kids with OI. But in both males and females, the fracture rates in people with OI continue to be much higher than in the general population. And down here, I highlight that in people with OI over the age of 55, the relative risk in women is 8 times that in the general population. So 8 times the risk of fracture in women, and in men, 5 times the risk of fracture in the general population. So in adults, as well as in kids, the risk of fracture is considerably elevated. We need, therefore, to know what we can do to reduce the risk of those fractures. The second thing, let me highlight, is from a poster presentation we gave a few weeks ago. My colleague Winnie Liu gave a few weeks ago at the ASBMR meeting in Toronto. Basically, what Winnie did was to use a large claims database, the market scan database, which includes records from 150 million people. We looked at those records for about a 15-year period, and we used a 5% sampling of Medicare to get older people and about 20 years worth of those data. Among those 150 million people were about 6,500 people with OI. 1,200 of them, almost 1,300 of them, we classified as having severe OI. They were people that used wheelchairs. About 5,200 had milder forms of OI, and 3,300 adults over the age of 18 years. And what I want to highlight in this table is the proportion of those people who had had any anti-fracture drug therapy during the course of follow-up. Here, in those less than 18 years old, so children, those with severe OI, 44% had been treated. Milder OI, 20% of those had been treated. In adults, the proportions were relatively low. Between 20 and 30% of people, of adults with OI, had been treated with an anti-fracture drug. Now, we don't know the indications that may have been present in all those 3,300 adults, but it seemed to us that that was a relatively small proportion of people with OI that had been treated, suggesting that there's a lot of opportunity to try and reduce fracture risk in adults with OI. So let's talk about what might be available to reduce fracture risk. First, of course, there's issues related to basic bone health, vitamin D, dietary calcium, exercise, and elimination of other risk factors. There's a variety of studies in people with OI to suggest that the rate of vitamin D deficiency is higher in people with OI than in the general population. So it's probably very important to ensure that vitamin D nutrition is adequate. Usual recommendations are 1,000 to 2,000 international units of vitamin D3 a day. But critically, people with OI should have measurements of their serum vitamin D levels to make sure that that level of supplementation is adequate. Dietary calcium is also important. Usual recommendations for adults with bone health issues is 1,000 to 1,200 milligrams a day of calcium of total intake. That means diet plus any supplements. What we don't know is whether it's appropriate to adjust for body size. Some people with OI have smaller body sizes than the usual adult population, and it may be appropriate to reduce this 1,000 to 1,200 milligrams if body size is considerably lower. Exercise and physical therapy, of course, important to improve bone strength and reduce fall risk. And then the reduction or elimination of other risk factors that might adversely affect bone health, other medications or medical conditions that might be present. It would be good to address those. So that's basically in all adults with OI. Who should receive additional pharmacological therapy to reduce the risk of fracture? It's probably true that not all adults are at high fracture risk and may not need drug therapy to reduce that risk. How do we decide who drug therapy might be appropriate for? These are some issues that are appropriate to pay attention to. People with OI who have had a recent history of fracture or who have had multiple fractures are probably at increased risk of additional fractures. And in those people, it would be appropriate to consider drugs to reduce that risk. People who have had vertebral fractures, particularly recent vertebral fractures, are probably at considerably higher risk of additional fractures. So looking for vertebral fractures with appropriate imaging modalities would be appropriate to identify those people. Bone density measurements can be very important, and lower bone density is probably associated with an increased risk of fractures. We don't know enough about this relationship in people with OI, but I can be pretty confident that the lower the bone density, the higher the fracture risk. And people with bone loss who have had bone density measurements repeatedly and are losing bone are probably worth paying attention to and can be identified as appropriate candidates for drug therapy. In addition, people with OI who have additional risk factors that we know are associated with increased fracture risk. For instance, it looks like menopause without estrogen replacement is associated with increased fracture risk in people with OI, like it is in the general population. Increased age, fracture risk goes up in anyone as age increases, and it looks like it's true in people with OI. So that may be a factor that influences the decision to recommend drug therapy. We know there are a variety of medical conditions or medications that reduce bone strength and increase fracture risk. And if any of those are present and can't be dealt with otherwise, might increase the need for drug therapy to reduce fracture risk. And people with OI who are at increased risk of trauma, specifically falls, might be more likely to consider drugs to increase bone strength and reduce fracture risk. So all these factors go into the decision that face a clinician and a patient in considering whether to undertake drug therapy. More of the conditions, the more likely drug therapy might be appropriate. What drugs can be used? The most common drugs used for increasing bone strength in osteoporosis and in osteogenesis imperfecta are known as anti-resorptives. Basically, they reduce the rate of bone breakdown and reduce the rate of bone loss. As you know, bone is always being broken down and new bone replaced. If we do reduce the rate of bone breakdown, then we can preserve bone and preserve bone strength. Those drugs are two kinds of anti-resorptives. The bisphosphonates, I'll talk about those first and most extensively, and denosumab or Prolia. I'm not going to talk about Prolia very much. Prolia is not used very often in OI for two reasons. First, there was a trial of Prolia in kids with OI that revealed a problem with hypercalcemia, high serum calcium levels, as doses of Prolia wore off. And that trial was discontinued for that reason and really gives us pause about using Prolia in people with OI. Secondly, there just has not been much experience at all with adults and the use of Prolia, so not much experience to draw on. So Prolia is not often used in people with OI. Bisphosphonates are the mainstay of therapy of kids with OI. We know a lot about the effectiveness of bisphosphonates in kids, and bisphosphonates probably are the most commonly used drug in adults with OI as well. There are oral bisphosphonates, pill forms, alendronate being most common. Risedronate is also easily available. And IV forms, usually zoledronate or reclassed. Pamidronate is occasionally used as well. Let me tell you a little bit more about the experience with bisphosphonates in adults with OI. First, there are very few studies. We know of only 5 or 6 studies of the effectiveness of bisphosphonates in adults with OI. All of them are limited by small size, short follow-up, and not a lot of power. This is an example of a placebo-controlled trial of alendronate in adults with OI, 64 people, average age 36 years. Almost all had type 1 OI. Here I show you the change in lumbar spine bone density in the people who received alendronate. over 3 years, and those who received placebo it, at the lumbar spine and at the toe of the hip. In this study, it looked like there was a clear beneficial effect. In the other studies, those benefits have been less clear. The other studies have also been observational in nature. In other words, there was not a control group, and that really limits the confidence with which we can interpret the results. So, summary notes about bisphosphonates in adults with OI. There are few studies, they're small, and they're infrequently designed with a placebo control. So basically, the evidence we have is relatively weak. Very importantly, there are no anti-fracture trials. So although we suspect that bisphosphonates increase bone density in people with OI, we don't have any confidence about the degree to which they reduce fractures. And of course, that's what we really need to know. The effects of bisphosphonate therapy on bone density and biomarkers of bone remodeling appear to be similar to those in trials of osteoporosis, but again, the evidence available is scanty. We don't have any good data comparing IV bisphosphonates like Reclast or zoledronate and the oral bisphosphonates like alendronate or Forteo, Fosamax. But most practitioners, I think, prefer IV bisphosphonates because they're more potent, they last longer, and they're more convenient. We don't know if there needs to be a dose adjustment based on body size. So in people with OI who are smaller, for instance, less than 30 or 40 kilograms, we frequently adjust the dose, maybe using doses that are similar to those in kids when we administer bisphosphonates. We don't have evidence that adverse effects are any different in people with OI compared to people without OI receiving bisphosphonates. We can talk more about that in the question session if necessary. We don't have good data about how long to use bisphosphonates in OI. We know a lot about that in osteoporosis, and we tend to use similar treatment approaches in OI as in osteoporosis. So again, the bisphosphonates are the mainstay of therapy in people with OI, but there are big gaps in the evidence that we have about their use. The other major kind of drug that we have available, again, pioneered in people with osteoporosis, are called anabolics. They're called anabolics because they don't reduce bone breakdown, they stimulate new bone formation. A very different mechanism of action compared to the anti-resorptives. There are two kinds of anabolics that are on the market. Again, they were developed and are on the market for osteoporosis, but we use them in people with OI. The first is parathyroid hormone analogs like teriparatide or Forteo or abaloparatide or Tymlos. And the second is sclerostin antibodies meant to inhibit a protein called sclerostin, which results in increased bone formation. There's one on the market called romosozumab or Evenity, and another one that I'll talk about that's in development called setrusumab. Let me talk about teriparatide or Forteo first. There is a little bit of data in OI. Similar drug called abaloparatide. I know of no data in OI, so I'm not going to talk further about it. There and 27 with type 3/4. Average age was 40, although the age spanned across the adult age range. What I show here are the bone mineral density changes in people with OI in the solid circles and the people with placebo in the open circles. On the left are type 1 OI, on the right side, type 3/4 OI. So it looked like there was a good response in terms of bone density in the people with type 1 OI, but the response in those with type 3/4 was not so apparent. There were similar trends at the hip bone density measurement site, and similar trends when we looked at bone density and bone strength in the vertebra using quantitative computed tomography. There's one or two other studies that looked at teriparatide in OI. They weren't placebo controlled, but they suggested similar effects. So a few summary statements about teriparatide. Again, there are very few studies, only one placebo-controlled trial. I showed you those results. The effects of teriparatide on bone density in people with OI look to be similar to those in people with osteoporosis, but again, only in type 1 OI. So the question is teriparatide effective only in type 1, but not in those with more severe OI? It looks like it's particularly effective in increasing spine bone mineral density, so might be most appropriate to use in people who have vertebral fractures or particularly low spine bone density. There is no evidence that adverse effects are any different in OI than in the general adult population, and it's a generally So we suspect that bone density is increased, at least in people with type 1, with teriparatide therapy. We don't have good data about whether that translates into a reduction of fractures. There's a large trial going on in Great Britain called the Topaz trial of teriparatide followed by zoledronate. That trial is powered to assess whether that combination reduces fracture risk. The results should be available in a year or two. So that should be very attractive or very useful. So drug therapy in adults. In contrast to the fracture protection that we can be pretty confident of with drug therapy in children with OI, there's limited evidence regarding fracture protection of either anti-resorptives or anabolics in the available drugs that we use to treat adults with OI. Nevertheless, we use these drugs with some evidence that they increase bone mineral density and with the presumption they should reduce fracture risk. Information about how to use these drugs, which drugs to use, when to use them, has to be a conversation, the result of a conversation between the clinician and the patient with OI, there's a lot of things to consider, and all those decisions have to be individualized. Now, I want to spend a little bit of time talking about drugs that are coming up for the therapy of adults with OI. Most prominent, that's setrusumab. I mentioned on an earlier slide that this is also, like romosozumab or Evenity, an inhibitor of sclerostin. And Dr. Glorio and his colleagues recently published, a few months ago, a trial of setrusumab in adults with OI. This is the basic design of that study. Adults with OI, both type 1 and type 3 and 4, were randomized to receive several doses of setrusumab. Some were initially going to receive placebo, but for a variety of reasons, they were quickly switched to the higher dose of setrusumab. What I'll show you are some results with this dose ranging study. They were very encouraging. First, the markers of bone remodeling are shown here. These are the changes in the bone remodeling markers over the 12-month course of the study at the 3 doses. The highest dose, 20 milligrams per kilogram, 8 milligrams per kilogram, and 2 milligrams per kilogram. There are 3 biochemical markers of bone formation: P1NP, osteocalcin, and bone-specific alkaline phosphatase. And you can see that they all had the same pattern: a dose-dependent increase in markers of bone formation. That's very encouraging. The last marker, CTX, is a marker of bone breakdown, and that was reduced during the course of the study. Also very encouraging. So we had increases in markers of bone formation and a reduction in markers of bone breakdown. So this is exactly what we want to see in drugs like this. Encouragingly as well, there was an increase in bone mineral density in the spine, again, dose dependent, with the highest doses having the greatest increase in bone density over the 12 months of the study. And this was a robust increase in bone density, much greater than we would expect with the anti-resorptive drugs. So again, positive findings. Very importantly, there were increases in bone density not only in type 1 OI, but also in the more severe forms of OI, types 3 and 4. These are the changes in bone density that I just showed you at the lumbar spine, with the lowest, intermediate, and highest doses of setrusumab. Again, a nice increase. But we saw similar changes, not as great, but increases at the total hip, femoral neck, and total body. So all positive changes with this new bone-forming drug called setrusumab. And there were changes in bone mineral density using another assessment tool, high-resolution peripheral quantitative computed tomography, which measures bone density at the radius on the top and at the tibia on the bottom. So there were increases in cortical bone density and total bone density at both those sites. Again, very positive findings. So these findings with setrusumab make us enthusiastic about the potential for anti-sclerostin drugs in osteogenesis imperfecta. Setrusumab is not yet approved for use. It's still undergoing additional clinical trials. But romosozumab, or Evenity, is an anti-sclerostin that's currently on the market for use in osteoporosis. And a question, of course, then is whether romosozumab should be used in OI. Is it effective in OI? The experience with setrusumab makes us very enthusiastic about that potential, and some people with OI are being treated with romosozumab. There's currently a trial being formed up with romosozumab and OI, and it'll take a few years, but we should have an answer to that question at some point. Some comments about follow-up. Should drug treatment be elected in an adult with OI? It's probably appropriate to have an annual physical evaluation to ensure that the drug is being very well tolerated and that the effects are as expected. Bone mineral density measurements every year or two are useful to ensure that bone density is at least stable, but hopefully increasing over the treatment duration. Other than routine laboratory evaluations, the usual recommendations are not to use special laboratory tests to follow the results of therapy. We can talk more about that in the question and answer session. In terms of treatment duration, again, we have very little information about how long, for instance, a bisphosphonate should be used in people with OI. So currently, we're using recommendations that are similar to those that we use in the treatment of people with osteoporosis. They're very patient-specific. We can get into those again in the question and answer session. And finally, a word about emerging therapies. We've talked about setrusumab. Very nice results were recently published with that drug, and we're looking forward to the hope that it will be approved. There's another drug called fragility, which is a TGF-beta inhibitor. TGF-beta, excess TGF-beta, is thought to have adverse effects in bone in OI. So inhibiting TGF-beta is the hypothesis that's being tested in very early clinical trials with a TGF-beta inhibitor. There are some novel anabolics that may be very active in OI. For instance, early clinical trial data were published in osteoporosis with a drug that not only inhibits sclerostin, like setrusumab and romosozumab do, but inhibit another inhibitor of bone formation at the same time. So the hope is that sort of that dual inhibition would have even more robust effects on bone formation. So all these things are coming up, and the point is that there are drugs in the pipeline that give us hope for additional therapies in OI. And the final issue that I want to bring up that comes up in questions sometimes is the usefulness of estrogen replacement therapy in postmenopausal women and testosterone therapy in men. I know of absolutely no data in OI. Of course, estrogen replacement therapy is good for bones and reduces fracture risk in women without OI. We can presume that estrogen replacement therapy would have beneficial effects on bones in women with OI. Of course, estrogen therapy is complicated, and there are a hosts of not only benefits but also risks to be considered with estrogen therapy in postmenopausal women. So it's a complicated decision and needs to be individualized. Testosterone therapy in men is even more complicated. There are no data that I know of with the use of testosterone therapy in men with low testosterone levels. In men without OI, that issue has gotten even more complicated in the recent past, since data suggests that although testosterone may increase bone density in men with low testosterone levels, the most recent clinical trials suggest that it might increase fracture risk, a very non-intuitive set of results. So testosterone therapy and its effects on bone are very controversial in men without OI, and I think it would be premature to use testosterone therapy to improve bone strength in men with OI. But we can talk about that more in question and answer as well. So, in summary, we know not enough about drug therapy in adults with OI, but there are options that can be considered in adults in whom drug therapy seems most appropriate. All those decisions should be individualized. A lot of individual factors come into those decisions, but there are options. So that's a brief summary of drug therapy for reducing fracture risk in adults. Thank you very much for your attention. Again, I'd be glad to answer any questions.